Welcome, welcome. Hi, Dr. Broderick. I am Rachel, your host and community manager here at Alloy Health. For those who might be new, Alloy is a digital health platform bringing evidence-based menopause hormonal solutions direct to your door. Our mission is simple: to make sure women get the care they deserve during perimenopause, menopause, and beyond. I am over the moon to welcome Dr. Meredith Broderick, a triple board certified sleep expert and clinician, to the Alloy platform. She attended medical school at The Ohio State University, completed a neurology residency at Case Western Reserve University, and a sleep medicine, behavioral sleep medicine fellowship at Stanford Medical Center. After training, she served as an assistant professor of neurology at Case Western Reserve University before transitioning to private practice in Seattle, Washington, and Anchorage, Alaska, where she has worked most of her career. She is board certified in neurology, sleep medicine, and behavioral sleep medicine. She's one of the only physicians in the country to hold this combination of board certifications. Dr. Broderick practices the full scope of sleep medicine, treating conditions such as insomnia, narcolepsy, parasomnias, circadian rhythm, sleep-wake disorders, restless leg syndrome, and sleep-disordered breathing, including all forms of sleep apnea. She has a special interest in treating insomnia without medications, utilizing a state-of-the-art treatment known as cognitive behavioral therapy for insomnia. Before we dive in with Dr. Broderick, I want to invite everyone, as I always do, to drop your questions into the chat for Dr. Broderick. I'll be facilitating those a bit later. And because we always want these conversations to feel supportive, if you're ready for next steps, we'd love for you to take advantage of today's discount code Broderick20, which you saw in the banner before we got started, as a little help along the way. Welcome again to you, Dr. Meredith Broderick. I'm so pleased to speak with you today.
Oh, thank you so much for inviting me. It's great to be here.
Just absolutely thrilled. Dr. Broderick, you have an immense amount of training. You are a specialist like very few others. You talk about becoming a great sleeper. What does that mean? And why do you think so many women in midlife have stopped believing that that's even possible?
Well, I think modern life is very taxing, and there are a lot of things trying to steal our sleep. And it also requires a certain amount of work. The same way I tell people, I think we take it for granted we should just be able to sleep. And maybe when we're younger, we are able to get pretty good sleep, but we're able to get by. You can sort of get by for a long time, and maybe you cross a threshold where it becomes more of a health issue. But the stresses of modern life, the 24/7 society, the electronics, I think it's all making it a lot harder. And then obviously our lives get more complex, and then we're dealing with perimenopause.
Right.
So I think things just kind of add up.
Yeah. Was there ever a moment, I'm curious, Dr. Broderick, in your own life when sleep completely fell apart, that you suddenly understood in a new way what your patients were going through?
Yeah, I mean, in retrospect, I had a hard time with sleep my entire childhood. And it wasn't until I did my sleep fellowship that I realized that there was something better possible.
Hmm.
And, I made it all through medical school, all through neurology training. And I had a really hard time with the on-call and the sleep deprivation. I think most people do. And so you sort of just go, everybody feels this way. It's normal, right? But when I went to Stanford and I saw myself and my patients and realized, oh, wow, there's another level of wellness here that I wasn't even aware of as somebody with all this medical training. That's when it really occurred to me that it was possible to level up.
Awesome. I can't wait to get into sort of what we need to know to get a really good night's sleep. I wonder if you could just sort of like frame us up with what's happening biologically during perimenopause specifically that starts to interrupt the sleep we once took for granted.
Yes. Well, I mean, relevant to Alloy, I think there are hormonal changes occurring. And then those hormonal changes that occur with, estrogen, progesterone, but also there are metabolic changes that happen as a downstream effect to that, in the sense that that has changes in our brain. It has changes on our total well-being, our mood, our sexual function. I think that, that's something that's, I think, very relevant to this community. But we also then develop more insulin resistance and a tendency to gain weight. And then that sort of lends itself to developing sleep disorders, something that's more kind of in my realm, like sleep apnea or chronic insomnia or restless legs, things that may have been easy to kind of deal with or manage and not be so big, but they just become a little bit bigger of an issue. And then you have a little bit more stress because you're taking care of kids and you're working and then your parents are aging. And so I think all of those things together are like the perfect storm, right?
Yeah, absolutely. I had mentioned to you before we got started that I was in a support group yesterday, and sort of the last third of the group ended up being about sleep specifically and the loss of sleep and just feeling like I'm doing absolutely everything. And it's interesting, and we're going to talk about this specifically, but this sleep apnea piece that some people may not realize they're struggling with. Maybe they sleep alone or they sleep beside a particularly heavy sleeper who's not hearing the disturbances in their breathing, and what kind of impact that has. We got into that, and I did encourage people to come today because I know we're going to really unpack all of that. You've said before that sleep is a skill. You just mentioned kind of like leveling up. It's not just something that happens to us. So how does the idea shift the way we approach sleep struggles in this season of life, recognizing that it's a skill, it's a practice, I guess?
Right. I mean, sleep is a behavior, much like, you know, eating or other sort of, primal things like relationships, things like that. And so if you think about it, it's important for you to learn how to sleep because you need to sleep. Sleep is a vulnerable state in the sense that if you think about pre-modern times, right, it's really cold, there's predators, there's other tribes. And so you need to sleep in a way that's safe. And that obviously means different things in modern times. But in that way, it is a learned behavior. And if you think about that, that's really helpful for humans because it helps them adapt to their environment. It's really obvious with kids that they learn how to sleep. If you're, a parent that lets your child share the bed with you, they learn to sleep next to a person and they feel like they need that to sleep, right? It's hard for them then to not sleep.
Right.
And there are some parents that train their kids to sleep in their bed, and then they develop that as what they feel is normal or what feels right to them and safe. And so those concepts still hold true for throughout our lives because we constantly do need to adapt and shift. And I think, I tell people all the time, you have to change your mindset. Like people might get stuck and say, well, when I was this age, I used to be able to do that. And I just think, well, that's not going to happen to you anymore because you were a collegiate athlete and you were exercising this much. And now your life is different. Now you're indoors all day and we need to make some adaptation. So that's what I really try to focus with people on is you kind of have to meet yourself where you are now in life in all regards, so your physiologic age, but then also your lifestyle and what does your life look like? When do you have to work? When are your responsibilities? When is the time for you to sleep? Where do you live? How much daylight it is? We think about all those factors.
That is fascinating. I have never thought about sleep being a vulnerable state. And when you say it, it's like, of course it is. And you have to feel safe in order to like even reach a baseline. That is so interesting. So to that though, uh, and sort of aligning it with our modern lifestyle, blue light blocking glasses, magnesium, melatonin, supplements, what's truly worth paying attention to?
I think all of those things are worth paying attention to. And I think of them like a toolkit. And I need to know which tool I need for which problem. And it sort of ties into what we were talking about before. So, like, one of the biggest problems now is people are on their devices and on social media and on the news and on their email in bed, right?
Right.
And so, safety might not be the right word, but it isn't my sleep place anymore. It's a place where many things happen, sometimes stressful, because I might get that email where I'm like,
Yeah.
and so we really want to train ourselves for this to be the place where I sleep. And so I think all those things play a really important role. So the blue light glasses, they're really helpful if you have a lot of LED lighting in your home. If you live in a place like I do, 47 degrees north, where it's light out till 10:30 at night in the summer. Magnesium, I think, you'll get mixed opinions on that, but I can just tell you anecdotally, there seems like it's really helped certain people. And having combed through the nutritional literature, it seems like because of the Western diet, because we don't drink water from streams and rivers and get as many greens, have more inflammatory food where we don't absorb magnesium as well, it seems like that is probably helpful in certain people, especially with poor nutrition or people who exercise a lot or a combination. But I think all of them are worth considering, looking at the person. And a lot of those things are very low risk to try. So, why not?
Yeah, super interesting. Let's pivot to hormones, the brain, and the body. So, starting with the brain, what role do estrogen, progesterone, and even cortisol, which I feel like is getting a lot of sort of like blowback lately on social media? I'm not sure why. Um, what role do each of those play in regulating our sleep-wake cycle?
Well, the way that I think about it is, with cortisol, I think about it a little bit different than estrogen, progesterone, but cortisol is one of the most important hormones that has a very well-known studied circadian rhythm. So we know that it almost follows the sleep-wake cycle, and we can predict, when will cortisol be high? It'll start being high while we're sleeping and then peak right after we wake up. And it's sort of tied with alertness as well. And then estrogen and progesterone, they do have a circadian rhythm as well, but the cycles are more pronounced with like what we call an ultradian rhythm, or the menstrual cycle, what we call it. And so, for perimenopause, we see shifts where there is more erratic levels, and that affects the brain because there are all these estrogen receptors in the brain. And we know that supplementing can really help with, brain fog and different menopause, perimenopause and menopause symptoms. So I just read Lisa Mosconi's book, The XX Brain and Menopause Brain. And, I love all the work that she does, teaching us about how that then pertains to brain health, and how if we can kind of ease this transition to having these less erratic, we can not only help women feel better, but we can also help them with brain health as well.
It's fascinating. Thank you for raising her to us again. We're fans of her as well, and the work she's doing is so interesting, as is yours. Dr. Broderick, this came up yesterday in support group. It comes up often. Why do so many women wake up at 1 a.m., 3 a.m., 4 a.m.? What is really happening in the body during those hours? Like 3 o'clock seems to be like the witching hour. I call it the witching. I don't know what happens, but a ton of people are up and frustrated and having trouble getting back to sleep. What's going on?
Yeah. So if you think about part of what drives us to sleep, it's having a sleep debt. So you can think of it like an appetite for sleep. And having an appetite for sleep, the way we develop that appetite is by being awake. So once you go to sleep and you sleep for 4 or 5 hours, your sleep debt is lower. So that's one thing. My sleep drive is lower. It is harder to go back to sleep a little bit in the early morning than it is, say at the beginning of the night. I'd say the second thing is that if you watch people sleep in the sleep lab, all people wake up after every sleep cycle and open their eyes and look around, but they don't remember it. So awakenings are normal. They're not, there's nothing abnormal about them, but sometimes people are distressed, like their expectation is to sleep through the night because they did before, and so I think that's another thing, is that some people experience that and it becomes distressing to them because they have such a busy life, they have such heavy demands, they believe that that itself is the reason why XYZ happens during the day, when it's really more multifactorial. And then it sort of develops a life of its own where, going back to that kind of safe space, this isn't a safe space anymore. This is a space where I struggle to sleep and I don't like that. And that itself sort of feeds on itself. And then there's other things too, like, perimenopause, menopause, you might be having a night sweat. You might have your partner snoring next to you because they're also going through the same things in life, and maybe they're waking you up, and maybe you're a little bit lighter sleeper at this age. So sleep apnea, that's a really common thing that's missed in women. And I have a whole thing about that, but it's multifactorial. I mean, really, to give you.
No, that's super helpful, because so it sounds like the 3 o'clock in the morning thing isn't necessarily a thing. It just might be coincidental that that's the hour that many people do get up and just feel more awake. And maybe it's because they have less sleep debt now. They've gotten some hours of sleep in. And also because we have probably woken up several times by then, but just don't remember. Does
Yeah,
that?
for instance, it could sort of start that way, as this sort of benign thing. Like, let's say, I have a meeting I'm worried about being late for, or early, I have to go get a mammogram, whatever. And then I just have a little trouble sleeping. But then the next night I go to bed and I wonder, am I going to have trouble sleeping again? And
Okay.
it sort of feeds on itself, where nothing is actually, and then maybe I'm going through perimenopause, so I'm already struggling a little bit, and this tips me over the edge, and then it develops into this behavioral issue where I just expect not to sleep because I'm worried because it's happened to me, 5 times this month.
Yeah.
And then that's where we really get into like a chronic insomnia issue.
Yes, and it's hitting me that that's also why cognitive behavioral therapy for insomnia is particularly helpful, because it's treating a behavior, not necessarily, I don't know, like an inability to go to sleep and stay asleep.
Right. And even I think just with CBT-I, we try to reframe even saying things like that to ourselves, like an inability to sleep. Like,
Mm,
no, your ability is there. And like I tell people all the time, when you eat food, you don't worry about that you're going to digest it. Like, your body knows what to do if you give it the right, if you kind of line yourself up correctly, your body knows what to do, but you have to trust it. But if you were sitting there worried all day, I mean, and I think this does happen to people. I'm worried I can't go to the bathroom, or I'm going to go to the bathroom at the wrong time. Then sort of the thoughts and the meaning we
yes.
make of it becomes part of the problem, right?
Yes, 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 it becomes a reality. Dr. Meredith, you mentioned light sleeping. Is there such thing as being a light sleeper, or is that a signal of something deeper, like hormonal or nervous system dysregulation?
Yeah, I mean, I think there's a spectrum, in the same way there's a spectrum of like how tall people are, or, their skin color. Like, there are some people that are intrinsically like lighter sleepers, is what we might call them. And I think the reason why it's harder for us to understand that is we don't necessarily understand in the brain what's happening. I mean, with all these trackers and even sleep studies we use, we're measuring brain activity from the surface of the brain, and not deeper, like what I would call subcortical or deeper areas of the brain. And I think, there are these people that are sort of sleeping with one eye open, is the way they may describe it, and they have more conscious awareness of what's going on when they're asleep. But it's not that their sleep is necessarily inferior. I think it's just a variation. And so that's part of, I think, what I try to help people understand as well, is
That's super.
yeah.
Yeah, you're like really tempering a lot of sort of fears and anxiety, I think, that most of us walk around with about sleep, and that's extraordinary. Dr. Broderick, sorry, I'm Dr. Broderick, Dr. Meredith. I hope you don't, whichever one comes out first.
It's good. It's all
Thank
good.
Thank you. How does hormone therapy fit into the sleep conversation?
Hormone therapy is extremely important for sleep, and it's bidirectional. So, I would say a large portion of referrals I get are from endocrinologists, and it doesn't just pertain to perimenopause and menopause. Yes, it does, but men who have low testosterone or people who have thyroid disease, all of those populations have a higher risk for having sleep issues, and then your sleep issues kind of make the hormonal issues worse. And so in my mind, it's really, the conversation should be like a both and, like we need to address both. So I want to see, menopausal hormone therapy. I want to talk about that for women where they're in that's the right, that's the right intervention for them. But oftentimes we do also need to look at the sleep angle, and how is that also, how is that also playing like both ways?
I really appreciate that. And it immediately makes me think of all the things we have in our toolbox. And what's right is right for the, I guess, condition that you're trying to address, if that makes sense.
Yeah, and sometimes it's hard to tell. So you need to, if someone is having night sweats and they have, it looks like perimenopause, sometimes you just have to say, let's try,
Yeah.
let's try hormone therapy. Let's reassess you how you are. And then if not, maybe we do need to add CBT on top of that. Maybe we do need to screen you for sleep apnea. I mean, there are some women that might have like a really mild upper airway resistance, or it's like kind of a sleep apnea light, like a really light version. And interesting, progesterone is a respiratory stimulant, and it actually can help with sleep apnea. I mean, it's not like a standard of care therapy we use for sleep apnea, but if you look at, people who've had hormone therapy, it can sort of reduce the severity. And, the reverse is true with testosterone. When you put people on testosterone, it can make sleep apnea worse if, not for like probably what is available for women, but more like the type that men might take.
So interesting. Um, you have said, Dr. Broderick, that light is medicine. Can you explain how morning light exposure helps, and correct me where I might be wrong here, retrain our circadian rhythm, especially for women whose schedules or sleep patterns have derailed?
Yes. Well, number one, light is very mood enhancing. And so we've all heard of seasonal affective disorder. There's a reason for that. But if we go back to pre-modern times and we think about that behavioral adaptation, not all animals sleep at night. Some mammals are nocturnal. Some mammals like whales, they have to swim around in the ocean all the time. They don't, and they sleep with half their brain at a time. And so the reason why humans sleep at night is it's the behavioral adaptation to our environment, right? Our vision is not very good at night. It's more dangerous. We take that a little bit for granted, I think, because we have all the city light and street lights, but if you're ever in like a remote area, it's very dangerous and scary to be out at night. It's also cold, and so if you're in pre-modern times, you can freeze, right? Or you can get hypothermic. So light, for that reason, because of this adaptation, it's very helpful to signal and keep the sleep wake cycle in order. Like I tell people, imagine what your life would be like if you don't have electricity, which for most people, that's like, okay, I went camping or I went on a retreat. And, we sort of lose some of these circadian rhythm disorders when we put people in that situation, because there's no other choice but to be active when it's light out. That's how it's meant to be. That's how we evolved for, 100,000 years. And that's
Yeah.
how our bodies are meant to interact with light. So you want to create that same, I think of it like a metronome for your body to follow, because that's when you'll get healthy hormones, healthy cortisol spikes, and things will be in alignment. Like, this is when I want to be awake, and this is when I want to be asleep, and what's going on in my body will be aligned with that. And the way you help signal and adapt yourself to your environment is using light to say, this is my morning, this is when my cortisol spike would be, and this is when I would also in nature be getting light, bright light.
That is the best, clearest explanation I've ever heard about why we want to be high functioning during daylight hours and really dialing it down during the evening. Thank you so much for that. Can we talk about temperature for a minute? How much do night sweats and core body temperature shifts drive insomnia? And what really is the best way to cool the body effectively?
Yeah, I mean, I think it's really kind of interesting to see the sleep tech evolving, because now we have all these really cool cooling mattresses and things like that. Obviously, we can temperature control. Going back to that, what I was saying earlier, it's meant to be colder at night, and our core body temperature goes down a little bit when we're supposed to be sleeping. And I tell people it's kind of like when you turn the thermostat down when you go on vacation, you're trying to conserve energy, because you're like, why do I, you don't think about it now, but you needed to conserve energy in pre-modern times, because you don't want to produce all this heat. So like your whole blood, there's a huge autonomic, I think of it like brain heart connection shift, where all this blood comes into my core and I protect my heat. And these autonomic changes occur during sleep. My core body temperature goes down. And so I think these are sort of, I almost think of hot flashes as like, or night sweats as like kind of autonomic dysfunction, where, and so, having the cooler temperature, I think that can help. It certainly isn't like a cure-all or going to help, but I think if you can mimic those environmental changes that would occur in nature to have a little bit lower thermostat, maybe a cooling device, like I think all those things are helpful, or even a fan.
Right.
Yeah.
Helpful. I've heard from many women, and I've experienced this myself, that perimenopause, menopause can bring on more vivid or even distressing dreams and nightmares. What's going on there physiologically? And is there anything we can do to kind of calm that nighttime anxiety that the brain seems to experience?
Yes. I mean, one thing that I think people don't realize is the brain is always having dreams, or what we might describe as nightmares, because all of this emotional processing and memory processing is occurring while we're asleep. What's happening, and the nature of our thoughts and the contents of our thoughts becomes a little more bizarre, disconnected at night and while we're asleep. I mean, that's where a lot of creativity comes from. But I think we become more aware of it when we have brief arousals within our sleep. So you kind of have to awaken during that dreaming and that brain activity during sleep to become aware of it and think of it. And then again, what's the meaning we make of it? So, there's a whole spectrum of like what I would call anxiety dreams all the way to nightmares. And the best strategies for that, I mean, sometimes it is an underlying sleep apnea issue. Sometimes it is related to trauma. There is something else medically going on, but a lot of it is about stress reduction during the day. So it could be as journaling, it could be a scheduled worry time, it could be exercise, it could be meditation, it could be breathing. Breathing is really helpful. But you're basically wanting to teach your sympathetic nervous system, your fight or flight. You want to bring the tone down and the overall stress in your life down. You want to just, try to get your autonomic nervous system, the parasympathetic and the sympathetic, more in balance. And so that would be my number one question for someone that's those are like the top things come to mind, is how stressed are you? Are you burning the candle at both ends? Is there something in your life that's really taxing you? 2, do I think you might have sleep apnea? 3, is there a history of trauma there? Or, those are kind of the top things that come to my mind.
Super helpful. Dialing in what's happening during, again, your waking hours, and sort of addressing that so that your sleep is kind of more peaceful.
Yeah, absolutely.
Okay, let's pivot to sleep apnea, something many women don't realize can affect them, especially during perimenopause and after. To begin, I guess, what's the connection, if any, between hormonal changes and sleep apnea?
Oh, well, we know there is a huge connection between hormones because women, before they go through the perimenopause and menopause transition, um, have a much lower risk of developing sleep apnea compared to men. That the estrogen and progesterone are protective. And after, when we see that hormonal shift, the risk goes up. And so that's another, compelling reason, in addition to the brain health and the cardiovascular reasons, and also quality of life, to consider hormone replacement therapy is for sleep. And so, yeah, I mean, I think it's just your risk of sleep apnea goes up,
It goes
right?
up
And
during
yeah.
the transition. I'm wondering why sleep apnea is so often missed in women, and what symptoms, if any, should we be paying attention to beyond snoring?
Mm-hmm. I mean, the short answer is that the way we detect sleep apnea, the way we measure it, is based on men. It was sort of designed for men. And so, um, you know, we just, there are different, what we call different endotypes of sleep apnea. So some people don't realize that we just think of the one type. We think of the person who's snoring and gasping for air and falling asleep in the recliner, right? But there's different endotypes. And the way that sleep apnea or sleep disordered breathing looks in women is much different. So the most common symptoms in women are actually insomnia, especially sleep maintenance insomnia. So I have trouble falling. I wake up in the middle of the night, I fall back to sleep. So that 3 a.m. awakening. If you have the 3 a.m. awakening, you need to get tested. And I mean, I see women every day that tell me, I know I don't have sleep apnea. Like, don't even bring it up. I'm not doing the test. That's not what it is. And my reaction to that is like, I hear what they're saying, and they could be right, but you can't know that you have sleep apnea unless you get tested.
Okay.
In the same way, you can't know if you have high blood pressure unless you check your blood pressure. You just don't know, right? And even someone will say, well, my spouse watches me and I don't snore. But the truth is that the bed partner is not a good indicator. Like, there have been studies around that. And then most bed partners don't watch you the whole night. How many of us would be like, let me stay up all night to watch you? Like, no, thank
Right.
you. So insomnia, fatigue, and headache, those are really common morning headache. And women will, because of that, they will get diagnosed with depression.
Yes.
So and there are studies showing that women have a higher cardiovascular comorbidity at having untreated sleep apnea. And so, I mean, basically, it's just our testing is sexist, or, it's like, it's not designed to really detect in women. So you have to have like a certain, you just have to screen more women.
Yeah. Thank you for that. I actually had tacked on at the end of my questions that sort of difference between testing men, testing women, and what we determine sleep apnea is about based on studies that were given on men. You mentioned higher cardiovascular risk as one of the health effects of untreated sleep apnea. Anything else that we should be aware of that should encourage any of us to get tested, particularly those of us who are struggling with insomnia? I feel like, not to be alarmist, but I feel like really many of us, given sort of I've tried everything that a lot of people say, might really benefit from testing.
Yes, definitely. So depression, migraines, especially in older women, atrial fibrillation, which is a very common heart arrhythmia. Those are people that, even aside from any trouble sleeping you're having, I want to screen you, because there's this other side of the coin that we rarely talk about. Like, we talk about insomnia a lot, we talk about difficulty sleeping a lot, but the other side of the coin is true too. There's people that are too sleepy, and we tend to call them good sleepers, but in fact they're not. They're sleepy. Their brains are, their arousal systems are broken. And so That's another important thing is like, if you're the kind of person that cannot stay awake through a television show, or, is dozing off unintentionally, things like that. It could even be like a micro nap. Those are things we want to test, get a person screened for. And I think some people avoid being testing because they're like, there's no way I'm using the CPAP. I just don't want to do it. Like, they don't even want to. But there's lots of other different options. And there's also the possibility, like I tell people, I know you don't want to wear a CPAP, and I understand that no one wants to, but if I told you that you would unlock another level of wellness and alertness and clarity, and you would sleep so much better, would you take this non-invasive treatment that is covered by insurance?
Wow.
And I would say, if you would just give me like 6 weeks to explore that, and if you hate it, then you hate it, we'd be done with it. But try it, consider it, open your mind to it a little bit, right?
Dr. Broderick, to the CPAP question, do people who agree to use it and try it, are you now committed to using it forever? Or is this sort of, do the things that you address, or the things that may come out of testing, help inform a new strategy that helps kind of rewire things, or sort of get you back on track? Does that make sense?
I think that it's both. There are some people where that's their long-term plan and they're happy with that. They really like their CPAP. It becomes a comfort to them. And then there are other people who now sleep better. They have more energy. Now they're going to be able to do lifestyle changes like exercise and eat better because they have this better metabolic health from getting sleep apnea treated. And then there are people who say, look, I'm going to go on a GLP-1. I might need my CPAP for a year until I get that weight off. There are some people that go and have, an orthodontic procedure, a dental procedure, an upper airway surgery, and then they don't need it anymore. So, and a little bit of that journey depends on how receptive the person is to those other options. And there's some people, they're not having surgery unless it's immediately life-threatening. And then there's some people that they will go and have a full jaw surgery and get off their CPAP, something really, invasive like that.
Yeah, yeah. Before I turn to questions that I see have come in, I just want to find out from you. Let's say someone is doing this 3 a.m. wake up thing. What's the worst thing they can do in that moment, and what's the best thing they can do?
The worst thing they can do is pick up their phone. I
Okay.
think. I think if you pick up your phone, it's going to be tough for many reasons. Some of those we already talked about. The best thing you can do is, something I talk to people about is, and this is kind of a silly analogy, but it's true, is your mindset is you want to think like, I'm waiting for a train to come and I can't make the train come and I don't know when it's coming and I have a choice. I can stomp my feet and I can curse and I can say, oh, this is so annoying. Why won't it come? Or I can say, how can I pass the time by while I'm waiting for this train that I know will come because it always does? And how can I pass it in a way that involves less suffering?
Okay.
And then there does reach a point though where you're waiting for the train for so long that it might be hard to maintain, after 20 minutes or so, you want to get up and leave the room and do something sort of boring and not that stimulating. And the analogy for that I use is like, imagine you were to go to the bathroom and all of a sudden when you got there, you're like, I don't have to go anymore. You don't sit there and wait for hours until you have to go again. You go, you know what? I'm not in the mood right now. I'm going to go, read a book. I'll read a chapter. I'll read 5 pages and then I'll try again when the urge comes, when the sleepiness comes back to me. And that's what we really want to do, is have more of this kind of accepting, letting it happen on its own instead of trying to control it and force it.
It's making me think of this, which I want to talk to you about, this sort of mind-body connection, just sort of being in tune with yourself and what you need right now to kind of dial back down. And maybe that is reading. It's definitely not your phone. I assume it's not TV either, but something that kind of gets you back into that state. Does that sound right?
That's 100% like bingo. And in order to be in that in tune with your body, that's why like TV is not good, your phone's not good, is because you kind of go out of your body for those things. Like with reading, you're very in tune. When you become sleepy when you're reading, your eyes start to get heavy, you're not taking it in anymore. You have to like read the sentence over and over. It's very clear I'm sleepy, and then that's a signal to you to go back. Whereas with TV, you can kind of like doze in and out and not really be aware.
Yeah. Oh, I've done that. I'm very guilty of that. This is fascinating. Okay, I'm going to turn to some questions for a moment and we'll get back to others shortly. This first one is about heart palpitations at night, and she says it doesn't feel safe to your safety comment earlier in our conversation.
Mm-hmm. Yeah, so heart palpitations, commonly might be something called premature ventricular contractions or PVCs. They're very common, and some of the things I might ask that person are, how much caffeine are you having? Because that can be a trigger. And then also, how much stress are you under? Because sometimes they can be augmented by stress. There are rare instances that people can have arrhythmias or some kind of sleep disordered breathing triggering them. So if you're waking up with them, that's something where we may actually want to monitor you with cardiac monitoring. So I think it would depend a little bit on like how old is this person, if they have other risk factors, how often is it happening, do they notice a clear connection between, so like if you're having 3 cups of coffee a day, you might try reducing to one and seeing if it helps. But that would definitely be something I would ask my primary care doctor about.
Okay. And I'd be remiss if I didn't say if you're also someone who's taking MHT or not taking MHT. And I know estrogen in particular can be so helpful for heart palpitations, but I also know that it's really important to get your heart checked anyway, especially over 40, 45, 50 for sure. Um, Next question. Do you have suggestions for how to get back to sleep when waking up every 1 to 2 hours throughout the night? Would it be, this really speaks to what we were just speaking to, but 1 to 2 hours sounds like a lot, maybe not. Would it be beneficial to try and stay up later in hopes of getting less total number hours of sleep, but maybe stay asleep without waking up so many times? That's an interesting question. Push your bedtime hour back?
No, that's a really, really good question. And something we didn't talk about is sometimes the reason people are waking up a lot in the middle of the night is because their sleep opportunity is too long. So again, thinking about that sleep appetite, it's like a yin and a yang. You do need to have a certain number of hours of wakefulness in order to generate a consolidated, continuous period of sleep.
Okay.
So I'll see this in people who are retired or have medical issues that keep them in bed a lot more. So if your time that you're in bed that you're allotting for sleep is like 9.5 hours, you're going to have a less continuity to your sleep. So in CBT-I, we actually use a technique called sleep compression, where we reduce the time in bed sometimes as much as 6 hours.
Really?
To what we're really trying to do is we're trying to use the intrinsic sleep drive from being up out of bed. And then it also augments that behavioral cue that I'm only asleep in bed because the sleep
Yeah.
drive and the compression is so high. So for someone like that, absolutely. Sometimes it's going to bed later. Sometimes it's getting out of bed earlier. And I kind of like to assess like what your circadian, like your natural circadian tendency is. So if you tend to be more of a night owl, yes, going to bed a little bit later could help. Whereas if you tend to be more of an early morning person, I might take it off. I might compress your time in bed on the morning side.
So interesting. Thank you for that. Any kind of magnesium that you would recommend for better sleep, or or is its effect on sleep minimal? So magnesium citrate, magnesium oxide, which one would you suggest?
Yeah. Again, I think that if you were to really say what's the evidence, I don't think we don't have it, but I do see just in my practice that it's helpful to people. mag citrate, people might have more side effects in terms of like diarrhea and things. So I think there is a trend more towards like magnesium glycinate or magnesium threonate, with the idea that maybe this is absorbed better even into the nervous system. So that's what I tend to recommend, is more, I go more away from mag citrate. But if you are somebody that has constipation, maybe that's not such a bad thing.
Right.
Yeah.
Next question, is there data that reading a physical book is better than listening to an audiobook? Obviously, one would have to pick up their phone or tablet to start an audiobook. That's an interesting question as well.
I don't know of data, but this is a question that is very interesting and becoming very relevant, and I think something that in our field we want to study. What I tell people when they do the audiobook, what's important if you're having insomnia. So if you're not having an insomnia and you just like to read at bedtime or listen to a book at bedtime, it doesn't matter to me that much. But if you are having insomnia and you're getting up in the middle of the night and listening, I don't want you to fall asleep on your couch listening to the podcast. And I think having, it's easier to close your eyes when you're listening to something. And then, because we don't want you to fall asleep on the couch, like going back to that going to the bathroom analogy, it's like having an accident for sleep. I want you to sleep in your bed. So it's very important that you have that body awareness and you notice I'm sleepy, and you take it back to the appropriate place, which is your bed, right? What we're aiming for. So that's the only thing about listening to podcasts I don't like, is when I'm dealing with someone with chronic insomnia who has difficulty waking up in the middle of the night. I'll say, you can listen to your podcast, but I want you to sit up with your eyes open. And then when you notice you're sleepy, go back. Because if you close your eyes, you lose that awareness and you just fall asleep on the couch or wherever you are.
Yeah.
I mean, I guess if you stay in bed, it's not horrible, but it probably depends on what the person wants.
Okay. Are there any foods or types of food you should stay away from that will disturb the sleep cycle?
So one thing that people don't talk about enough, I think, is there's a couple things I think about with food. One is reflux becomes more of a problem as we get older, and that can really interfere with sleep.
Sure.
People can even wake up thinking they have sleep apnea when they're having like a vocal cord spasm or something like that because of reflux. So not eating within 3 hours of bed. So timing is very important. The later you eat is also going to shift your circadian rhythm and then all those hormonal patterns as well. So if you're trying to go to bed earlier and you're eating, within an hour of bed, like that's working against you.
Right.
And then some foods are going to be more prone to triggering that reflex, right? Like spicy food, things that are really acidic, tomato sauce, and
And I know it's so spoken about, but alcohol is a big thing, right? Especially for this community that, just any of it after a time for many, many women starts to become too much and can trigger night sweats and all of that.
Yes, absolutely.
Yeah. Okay. I was diagnosed after testing with apnea, and once it was explained to me, I did some research. I'm skinny, so that wasn't the reason. Could have been perimenopause, I don't know. I did try sleeping on my side instead of my back, and I do not suddenly jerk awake, gasping for air anymore. I just hope that you can check that out and maybe help others. She may have been commenting to everyone here on the call, but that's interesting too, that she is somebody who didn't need to lose weight. She was tested. She discovered, in fact, that she is dealing with sleep apnea, didn't have that sudden jerking or gasping for air anymore. Anything more you can tell us about sleep apnea and any anomalies, I guess, that we should be on the lookout for?
Yeah, I think going back to that sexist way that our sleep testing works is a lot of women are going to show milder sleep apnea on the rating scale, and they're going to think, oh, it's mild, I don't need to do anything about it, or it's not connected to the symptoms I'm concerned about, like
Right.
insomnia. Um, and so for someone like this, it's very important to get post intervention treatments or testing, excuse me. So she may notice my sleep apnea seems better because I'm not jerking awake, but she may still have fairly significant sleep disorder breathing going on, but it's just not apparent. So positional therapy can work. There are some people that, because they have what's called like a tongue-based collapse, so when they're on their back, their tongue just tends to fall back. And mechanically, it is more difficult to breathe when we're laying on our backs as well, in terms of just the way our abdominal contents affect our lung anatomy. And so positional therapy can be very effective, especially if you are, a healthy weight. But we do want you to have testing with positional therapy. And usually people need some kind of device, like sort of just saying, oh, I'm just going to sleep on my side. Like that usually doesn't work that well, because I have people that come into the sleep lab and they tell me I never sleep on my backs, and we watch them do it. They just don't know. So I think that's the thing about sleep, is you can't sort of use your own sense. Like you do need to have some objective input. And even if you're mild, you still need to do that.
Okay. Dr. Broderick, beyond the CPAP, you mentioned there are other things that can be helpful. I don't want to sort of like throw stuff out that people may, I don't know if you can just go purchase stuff and maybe you don't need it. It sounds like you really need the testing, but I'm just curious what else is out there for people struggling.
Yeah. So for people that have more of like the tongue-based collapse, there are these dental devices that hold the lower jaw forward. We call them oral appliances or mandibular advancement devices. And there's a whole field of dental sleep medicine that specializes in that. There's also all these airway orthodontic treatments that involve expanding the arch, the dental arch, and the roof of the mouth, the palate, and then, basically creating more room. So our tongue should naturally sit suction lightly to the roof of our mouth. And some of us, including myself, had allergies growing up. So I was a mouth breather. I did not have good tongue posture growing up. I had very narrow dental arches. I had a crossbite. And even though I had orthodontics, it didn't fully put me into the ideal alignment. And so, and I didn't develop all, sort of to the healthiest oromotor patterns that I could have. And so, and then of course I still had allergies, so I wasn't a good nasal breather. And so all those things are important, like allergy treatment, orthodontic alignment, having space, just anatomically having a healthy airway, having, if you have a deviated septum, if you have enlarged turbinate in your nose from allergies or other causes. Sometimes people have polyps or sinus issues. Those can all help. Like anything that involves our breathing is going to help us sleep better. There's also things like the GLP-1. So obesity is the most important modifiable risk factor for sleep disorder breathing. And so even for someone who's not, maybe their body mass index is only like 26 or 27, getting them below a body mass index of 25 is very, very helpful. So GLP-1s are now part of the standard of care treatment for sleep apnea in people that are obese or overweight. And then there's also there's a nerve stimulator surgery. There's many types of jaw surgery and upper airway surgery. So tonsils and adenoids coming out, moving the tongue forward with these little, what we call genoglossus advancement. There's like a whole,
It's a
menu
whole
of
world.
surgical options.
I had no idea. Thank you for that. A couple more
Yeah.
questions before I turn back to some others that I had for you. And Dr. Broderick can give us an extra 10 minutes, thankfully. So hopefully we'll get through everything, which would be very exciting today. The person who brought up magnesium is also asking if you can address magnesium threonate or threonate. I'm not sure if I'm pronouncing it correctly, actually, but can you
Mm-hmm.
speak a little more to that specific one?
Yeah. So I don't know where they heard that, but I know there was a podcast. There's a pretty popular podcast where that was brought up that there's better penetration through the blood-brain barrier, and so that it's better. So I think there is this idea that that may be more bioavailable for the brain if you take that type of formulation. I think that's why. Again, we don't have good research to show, like most of the research is actually around like, magnesium citrate and magnesium oxide, just
Right.
because I think this is a newer trend to see that magnesium glycinate and magnesium threonate. So it's a little bit speculative, I think, but I do think that we know the side effects, for like the GI side effects are more favorable with like the glycinate and the threonate. So I do tend to recommend those formulations.
Okay, great. She did mention that with progesterone and the 3 and 8, her restful sleep has increased dramatically. So that's good to hear. Um, this is interesting. What about the opposite side of the coin? What about people whose body has always felt like it needs 10 plus hours of sleep a night, who are super duper sleepers, who always feel groggy when they wake up, who are always slow to wake up and become more and more awake as the day goes on, instead of waking up rested and getting more tired as the day goes on. Side note, she says these people don't drink caffeine. This is really interesting.
Yeah, so there's a number of different perspectives from a sleep specialist. So there's something called a biologically long night. So a lot of us think about melatonin deficiency and wanting to supplement, with melatonin because there's an age-related decline, blah, blah, blah. But there's also people who secrete too much of it and have what we would call like a biologically long night. And because of that, sort of manifests this way. So that's one thing I would think about. We sometimes give those people beta blockers because that inhibits the pineal gland from producing as much melatonin. Also, light therapy is very important to sort of suppress melatonin. There are also people so we might call them like long sleepers. So again, we're talking about variation. There are some people who
Right.
need 4 hours of sleep. That's rare. There's some people that need 10 hours of sleep. That's rare. But there's also a set of conditions called primary hypersomnias. Narcolepsy is the one that most people have heard of. And that's something that would be high on my list to consider. And then also screening for sleep apnea or other types of things that would disturb the quality of sleep and make that person need more sleep to sort of function. Those are the things that I would be really concerned about. And those things are also very underdiagnosed, and there's like a lack of awareness. So you need to see someone like me in order to tell you, is this a normal variation or is this something else?
Yeah, thank you for saying that. Ultimately, I like my biggest takeaway is we all need to see a sleep specialist because we have no idea what's happening when the lights go out. And we do come up with all of these sort of in an earnest want to understand why we're not feeling rested when we wake up in the morning. But there is a lot that we don't know. I have never heard of long sleepers or a biologically long night. And it seems like these are things that more of us should know about. One more question. How does a female diagnosed with ADHD, how is her sleep affected? Is there any correlation there with ADD, ADHD, and sleep?
Yeah, I mean, sleep doctors think that a lot of people diagnosed with adult onset ADHD are probably living with a sleep disorder. And it's really important to try to make a distinction.
Whoa,
Because
really?
if you think about it, the symptoms of sleep disorders are very similar. Like I have difficulty sitting still, I have difficulty paying attention, my concentration isn't good, you know. So can they coexist? Of course they can. And then the medication titration is really important too. And there's a whole behavioral, I think, aspects to it as too, just helping people adapt and helping people develop healthier strategies to cope with it. But yeah, I mean, I have people all the time that are diagnosed with ADHD or depression or you name it, and we diagnose and treat their sleep disorder, and that is not relevant anymore. Because there's no definitive test for ADHD or for menopause for that matter. It's a clinical diagnosis, right? You talk to the person and you put the puzzle together and you go, yes, that's what it is. But sometimes there's so much overlap that it's hard to really tell. So in a way, you just go, let me treat you for this and see if you feel better, right? And if you do,
Yeah,
then we kind of know.
and we kind of know. Amazing. Thank you for that question. Um, Dr. Broderick, when should someone consider CBT-I, cognitive behavioral therapy for insomnia?
Yeah, to give a very like a concrete answer, there is a validated questionnaire called the Insomnia Severity Index. And it's a very simple screening tool that you can take online to tell you how severe your insomnia is. And it helps us know if it's severe enough for CBT-I. We also don't want CBT-I for someone who just started having trouble sleeping 2 weeks ago. It's meant more for when these sort of maladaptive behavioral patterns. So we say like more than 3 times a week for more than 3 months is chronic insomnia. So we want there to be some pattern to it, but also maybe some severity that would be reflected by a survey like that, the Insomnia Severity Index.
And you may have mentioned this earlier, so forgive me if I missed it, but you want to see somebody who's a specialist in this, correct? As opposed to like I'm going to talk to my therapist about not that your average therapist may not know, they might, but who do you want to reach out to about this?
Yeah, I mean, there are therapists that do take a weekend course, and I think some of them do okay. I do think there's still a lot of lack of awareness where people think that sleep hygiene is a treatment for insomnia, and it's not.
Yes, we hear it all the time. My gosh, can we stay here for a second? Sleep
Yes.
hygiene is like the thing. And on social media, and I'm guilty of this myself, how do we talk about how to get a good night's sleep? Sleep hygiene, make the room cool, make the room dark, blah, 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 blah. Women are still suffering. And actually, the support group last night, this woman said, emphatically, like, my hygiene's good, and I'm sure it is. I had no reason to doubt her, but it's not enough. Can you expand on that?
Yes. Sleep hygiene is something for everyone. It's a health promoting behavior. So the term was coined actually to be, similar to dental hygiene, like you brush your teeth and floss every day. And that's not treating your cavities, but it's helping you not get them. So sleep hygiene should be our baseline. But I still see a lot of primary care doctors sort of prescribing sleep hygiene for people with insomnia as first line. There are a lot of digital programs, apps, and things like that I think can be helpful. And so you can approach in a stepwise care, because finding someone like me is a little bit difficult because there's not that many of us.
Yeah.
I think there's only a few hundred CBT-I boarded people in the country. And there's like for sleep medicine, even a lot of sleep medicine doctors are not trained in behavioral sleep medicine. And they're so busy because there's one sleep doctor for like every 45,000 people in the US or something like that. And
Oh,
so you really need to see someone like every week or every other week for CBT-I. It really needs to be like a very concentrated treatment. And, it's interesting, like how you said, someone will say like, I have really good sleep hygiene, but in a way, when you see someone like me compared to like a digital app, when you really have someone interrogate you and shine the light on you, sometimes you find it's not true, and you are thinking that's not what it is. And sure, maybe that one thing isn't the cause of my insomnia, but I need to do like a set of things in order to like get where I want to be. So
yeah. I'm laughing because when I said it, when it was coming out of my mouth, I was thinking about you're saying that you have patients come to you and say, I never sleep on my back. And sure enough, you're watching them sleep and there they are on their back, right? We just don't know what's happening when we're lights out.
yeah, and part of it is that when you interview someone one time, you're forced to make a generalization, right? Like when your doctor's interviewing you, you're forced to make a generalization. And so when you do something like CBT-I, you just get more detailed and you zoom in and you pay there's a greater attention to the details. And with CBT-I, for some people, the devil is in the details, and that's where they really So I get a lot, like a lot of my patients have tried a book or an app before, and they're like, I got a little ways, but I'm stuck here. And so, I kind of help them finish it off.
Okay. Dr. Broderick, what are your sort of three evening habits that can, for many patients, many women, make the biggest difference for energy and focus the next day? I feel like I don't, maybe this, you'll be repeating yourself. I don't mean for you to do that, but if there's anything that I've missed or that you didn't get to mention about, getting a good night's sleep, what would you add?
Yeah, I mean, you want to set the mood. If you think of sleep like a behavior, like our sexual behavior, our eating food, we set the mood, right? When we have a meal with other people, we set the table. It smells good. Like we don't talk about things that are disgusting at the table. Like you want to set the mood. Same thing, in other behavioral domains. So you want to set the mood. So if you're somebody who's checking your email all the way up to the time you go to bed, if you're someone who feels like you can't take an hour at least before bed to sort of dim the lights, relax, kind of just let your day unwind and give yourself a cue to get in the mood, lower the temperature, don't be eating anything. Though I would say that's really important, is like setting the mood. I think people really underestimate, but the brain, it wants to recognize a pattern and follow into it. And if you tell your brain, every time I set that mood and I wind down, I set out my clothes for the next day, I dim the lights, the temperature goes down, I'm not eating, I'm not checking my email anymore. It allows the brain to sort of prep, because we think of sleep being like consciousness goes off, like it's a switch, but it's not. It's like more like a dimmer, where this process of distribution of blood flow, temperature, it starts to happen. It should start to happen before we actually go to sleep. So we need to give a marker for that, like the metronome. And then
Right.
our brain will start to recognize that pattern and fall into it.
Oh, that's so helpful. Thank you, Dr. Broderick. I'm, we're winding down, but anything I've missed that would be sort of included in your sleep survival kit or your toolbox for great sleep. You've given us so many helpful nuggets, tools, strategies, and really, I think, encouragement to find somebody who can help us create new habits and get a good night's sleep. Anything else that you think I've missed?
I mean, I would just say it's a journey. It takes time, and be dedicated to the process. I'm sure you tell your clients the same thing with menopausal care, that, yes, we can give you this, hormone replacement therapy, but we may need to adjust it a little bit. We may need to tweak this medication or dose it a little bit this way. And that can take 3 months, or it can take 6 months to just find what works for you. And then we may also need to, if your life changes a little bit, your job changes, you have a major life change, may need to adjust that. It's a practice that you continue through your whole life. It's not like a one and done type of thing.
So helpful. I'm getting, okay, I get so excited, but I like, it's just hitting me that there are things that we really do overlook. We assume that we're going to lay down and get a great night's sleep, but things change for any number of reasons. And it is a journey, and sometimes it's an effort and it needs more attention. This is a funny question to end on, but I'm super curious, Dr. Broderick. What does rest mean to you now, both as a physician with all of this knowledge and as a woman in this season of life? Rest specifically.
I think it's really being more in tune with like that intuitive side and letting things happen. I think of it more like creativity. And I think a lot of us think we need to be goal oriented and engaged to like a specific task in order to be productive. Whereas like for me, if I just take time out of my day to go for a hike for a couple hours and I'm not working, but a lot of ideas may come to mind, a lot of problems may be solved because I just gave I gave my brain the chance to solve problems instead of be tasked with something all the time. And I think that's a type of rest that we all need. It's like a kind of a blank space that we
Mm.
all need to sort of yin and yang ourselves into like a more balanced place.
Ah, I love that. Thank you. I just noticed a couple more questions,
Okay.
and do you have time to answer a
I
couple?
do. I do. Yes,
Oh,
I would love
we're going to
to.
take 3 more minutes. Thank you. One is, how can we enhance our REM sleep or expand it? Is it possible to do?
Yes. So REM sleep is one of the two deep stages of sleep. It's not the deepest stage. Some people think it is, but slow wave sleep is our deepest stage. And the depth of sleep, when we think of deep sleep, what do we actually mean? It means it's the time that it's hardest to wake someone up. So if I were to play a tone, it could be lower in a lighter stage, it would wake the person up. Whereas in a deeper stage, it takes a little bit more. So in other words, you're more disconnected from your environment. Um, so I know people want to get REM sleep, but it's interesting because and I think wearables have kind of played into this, but it's interesting because it's not necessarily going to make you feel more rested. There's a healthy balance. So for instance, if you look at people with depression, they have much denser REM sleep, sometimes more of it. And it's an indication of emotional processing happening. So more is not necessarily better. That's the one thing I would say is more is not necessarily better, but there are times where you might not have good REM sleep because of a medication, because you're not sleeping in alignment with your circadian rhythm, because you have sleep apnea, because you have insomnia and your sleep is more fragmented. So those are the things that would come to my mind. But I also think I would say, you know, don't look at your tracker and if it says you're getting 17%, think, oh, I need to be the textbook 20. That is not necessarily true. One, your tracker may not be accurate, but it's sort of not an outcome that we measure or follow in any way clinically in sleep medicine.
Are you a fan, by the way, of wearables? And some people love it. I don't have one. I feel like it will make me more neurotic about a lot of things, but I'm curious what you think.
I'm really excited about them in the sense that they can help us a great deal, but I just don't think they're there yet in terms of being able to deliver. You know, I think they're going to help us screen people for sleep apnea, for high blood pressure, just because we have access to track people more often, like throughout their days. Um, but I don't think they're helping us yet get people like there's one aspect it's called the Hawthorne effect. It's actually something we've observed in research, which is if you watch people, if you study people, they'll behave better. And so some people do get that benefit from a wearable. They sort of feel like someone's watching them, so they do pay more attention to like do their have a consistent bedtime and wake time and some of those sleep hygiene things. So there are those people that I think do benefit from it, but whether it's sustained over the long term, I don't know. I think I'm working with a company now where we're trying to um, develop these what are called like just-in-time interventions where we're using this data to actually give people information that can be useful for helping them rather than just collecting their data and not having them not really know what to do with it.
Last question, and this is in fact the very last question. And Shamika, I'm so glad you're here. Thank you. She's thanking Dr. Broderick. So yeah, this has been an unbelievably fantastic call. But our last question is being a morning person and a night owl a real thing? Hypothetically, would people function better if they could sleep, wake when their bodies naturally wanted to? You spoke about this in the beginning, I think.
Yeah, they are real. And we do even have down to the molecular level know why
Really?
this is. I mean, there are genetic reasons for it, but if you have really intense Zeitgebers or timekeepers, where if you take away all artificial lighting from people and you put them in nature, those chronotypes sort of disappear a little bit because people do entrain so well to like the signals from the sun outside are so much stronger than indoor artificial lighting. Um, but we don't live under those conditions anymore. So yes, in these artificial lighting, those things do exist, and we sort of want to optimize it. And another way I think of it is like, if you think about the original humans, right? We think that they emerged in Africa, where there's a more balanced light dark cycle, right? It's more like 12 hours and 12 hours. And there's a whole really interesting thing about that in terms of like, if you look at apes, they sleep longer than us, but they also sleep in trees. So we think one reason humans sleep less is because it's more dangerous to not, to sleep on the ground. But then when humans started migrating north into, let's say, like Northern Europe or the Scandinavian countries, you have to have a different type of adaptation, right? You have to hunt and gather all summer like crazy and get all your food and store it for the winter. And you might want to be less active and sleep more in the winter and kind of have more of a, not a day-to-day balance, but over the year. And I worked in Alaska for a long time, for 5 years. And it's really interesting because that people are seasonally adapted. So it's not just like day to day, what's my balance? And I do the same thing every day, but people do sort of have like more energy. They get more done in the summer. And then there's like almost like this mini hibernation.
Yeah.
And so if you are, and the same thing is like, if you're, have a darker skin color, the sun doesn't quite affect you. Like you need more to get more vitamin D. Whereas if you're from a more Northern European, like you are more sensitive, so you don't need as much to get your vitamin D. So there's those things too, that where it's really interesting to look at people's ancestry, and like someone of a more Northern ancestry may be more sensitive to these light, dark variations, just because, genetically that was part of how they evolved to adapt to their environment. Yeah.
Fascinating stuff. Dr. Meredith Broderick, I could talk to you all day. Please say you'll come back again and speak with us. Thank you so much for this conversation, and I ultimately reminding us that good sleep really isn't a luxury. It's a sign of our health. To everyone watching, thank you for being here. I'm sure that you're walking away with really practical shifts and a renewed understanding of what's possible. You can learn more about Alloy's care and resources at myalloy.com. Until then, take care of yourselves. Do what you deserve to get a good night's sleep tonight, and take care of yourselves. Thank you, Dr. Broderick, so very much.
My pleasure.
It's been phenomenal. I do so hope to talk to you again. Thanks, everybody. Be well.